site to thrive and multiply.
Wow. It really highlights how different pathogens exploit different landscapes. Gonorrhea struggles with the postmenopausal cervix, but Trichomonas absolutely loves the postmenopausal pH shift.
That's a perfect way to put it.
And speaking of pathogens that linger for decades, let's look at the data on syphilis. The numbers here are genuinely alarming.
Syphilis is a notoriously deceptive disease. It is caused by a spirochete bacterium, and it unfolds in very distinct stages over a long period of time.
Okay, what are the stages?
Early syphilis, which encompasses the primary and secondary stages, usually features highly infectious open sores, called chancres, followed by a widespread body rash. If it is caught in this early stage, it is easily cured with penicillin.
If it's not caught.
If it is ignored or misdiagnosed, the symptoms eventually vanish. The disease goes dormant into what we call the latent stage.
It just hides.
It retreats deep into the body, and it can stay in that latent stage for years. Eventually, it progresses to the late stage, where the bacteria begin to attack the internal organs, the cardiovascular system, the brain, and the central nervous system, causing irreversible neurological damage and cardiovascular failure.
That is terrifying.
Yeah.
And when the Hopkins researchers looked at the data for early syphilis, the active sores and rashes, the rates were actually relatively similar across the age groups.
Right.
They hovered around 1% for both young and older men, and around 0.5% for both groups of women. Not a huge difference. But then they looked at the data for late or unknown stage syphilis. For younger adults, the rates were around 1.8% to 2.2%.
Yes.
But for older adults, it was a massive, terrifying jump. 7.5% for older men and 7.5% for older women.
That 7.5% figure for late-stage syphilis in the over 50 population is a textbook, tragic example of accumulated risk. Because syphilis can remain completely asymptomatic in the latent phase for decades, what we are seeing in that 7.5% is the dark legacy of a lifetime.
I was trying to find a good way to visualize this. It's kind of like a slow burn financial fraud within the body.
I like that analogy.
In your 20s or 30s, the hacker, the bacteria, steals a tiny bit of data, maybe leaves a small glitch you barely notice, and then buries itself deep in the code of the server.
Right.
For 20 years, the system runs fine. You have absolutely no idea the hacker is there. But by the time you're 60, they've silently siphoned out the foundation of your accounts, and the entire system crashes.
Yep.
These are infections that were likely contracted during the disco era, went completely undetected and untreated, and are only being discovered incidentally now because these patients finally came to the clinic for a screening or some unrelated issue.
The slow burn fraud is a very apt way to describe it. It's structural damage happening in the dark. And finally, let's look at the HIV statistics within this specific Baltimore clinic population. We already discussed the national trend of 21% of new cases being in seniors, but in this specific data set, the older women were incredibly vulnerable. Older women had a higher proportion of new HIV diagnoses at 2.3% than younger women, who were at 0.91%.
That is a staggering disparity. A woman over 50 walking into that clinic was more than twice as likely to leave with a brand new, life-altering HIV diagnosis than a woman under 50.
Yes, she was.
It completely validates everything we discussed about the condom gap and the biological vulnerability of postmenopausal tissue.
It is the inevitable clinical outcome of those behavioral and biological factors colliding.
So we have a map of the problem. Looking at age and sex gives us a clear topographical view of who is getting what disease. But public health isn't just about describing the present, it's about predicting the future. It's about knowing why certain people are at risk so you can intervene before they get sick. When the Hopkins researchers wanted to predict who was most at risk, they ran predictive statistical models. And when they factored race into those models, they uncovered a massive statistical paradox that completely breaks our understanding of risk.
What's fascinating here is, this is perhaps the most sociologically profound finding in the entire 183,000 visit dataset.
Really?
Oh, absolutely. To set the stage for why this is so baffling, we have to understand the specific demographics of these inner-city Baltimore clinics. They serve a predominantly African-American population. In the study, about 88% to 91% of the patients across all the age groups identified as Black.
Right. So the researchers want to figure out what factors actually predict whether a patient will test positive for an acute STI. They run a statistical analysis called a logistic regression.
Yes.
Now, before we give the results, can you give us a quick explanation of what a logistic regression actually does and what an odds ratio is? Let's make sure we all understand the math behind the mystery.
Absolutely. Think of a logistic regression as a highly sophisticated sorting machine. If you want to know what causes a heart attack, You can't just look at weight, because heavier people might also smoke more.
Right, the variables are mixed up.
You need to isolate the variables. A logistic regression allows researchers to look at a specific outcome, in this case, testing positive for an STI, and mathematically hold all other variables constant to see the true impact of just one specific factor, like age, or sex, or race.
Okay, that makes sense.
The result is expressed as an odds ratio. An odds ratio of 1.0 means the factor has zero effect. An odds ratio of 2.0 means the factor makes you twice as likely to have the outcome.
Okay, perfectly clear. So the researchers run this sorting machine on the younger demographic patients under 50, and the statistical baseline they found was tragic, but very clear.
It's what we usually see in public health.
Yeah. For the young cohort, Black race was a strong, highly significant predictor of having an acute STI. The odds ratio was 2.2 for young men and 2.7 for young women.
Right. And to translate that using the tool we just explained, an odds ratio of 2.2 means that in this younger group, a Black man was 2.2 times more likely to be diagnosed with an acute STI than a white man walking into the exact same clinic, even when the math controls for other factors.
Wow.
For a young Black woman, she was 2.7 times more likely. Now, we have to be extremely clear here. In public health research, race itself is not a biological risk factor for bacterial or viral infections. A virus does not care about your melanin.
Obviously not.
Instead, in younger populations, race unfortunately acts as a highly accurate proxy for a massive web of systemic inequalities.
What kind of inequalities are driving a 2.7 odds ratio?
It acts as a proxy for lower socioeconomic status, historical disenfranchisement, a severe lack of access to quality, preventative primary health care, and underfunded community sexual education.
That makes a lot of sense.
Furthermore, due to residential segregation, it reflects tighter, more insulated sexual networks. If an infection enters a dense, insulated network where people struggle to afford doctors, that pathogen becomes highly concentrated within that specific demographic group. That is why the odds ratio is so high for young Black patients.
And that is the tragic expected baseline in almost all American public health data. Systemic disadvantage breeds disease concentration. But here is the anomaly that totally blew my mind.
Let's hear it.
When the researchers ran that exact same logistic regression sorting machine for the patients aged 50 and older, the proxy completely vanished. Race completely ceased to be a significant predictor.
It's incredible.
The odds ratio plummeted from the 2s down to essentially neutral 1.2 for both older men and older women. It was no longer statistically significant.
It is a phenomenal finding. What the math is telling us is that the structural systemic disadvantages that definitively drive health disparities in youth somehow evaporate or are completely overridden in the specific context of sexual health as people age.
So wait. A white man over 50 and a Black man over 50 walking into that Baltimore clinic had virtually the exact same mathematical risk of having an acute STI.
Yes, exactly the same risk.
I am still struggling to wrap my head around the why. How does a massive, entrenched socioeconomic predictor just vanish because someone blows out 50 candles on a birthday cake? The study dug into this, didn't they? What are the theories?
The researchers absolutely tried to untangle this because it is so incredibly counterintuitive to everything we were taught in epidemiology.
Yeah.
Their first instinct was to look for a biological explanation. Is there a difference in acquired immunity over a lifespan?
Meaning, did one demographic catch more of these bugs in their youth, clear them, and develop some sort of localized immunity that acts as a shield later in life, balancing the scales?
Exactly. To test that theory, they looked at the patient's self-reported previous STI histories. If the Black older patients had far more previous infections, maybe they were now immune.
And what did they find?
They found that a previous history of STIs was indeed linked to higher rates of current infections generally across the board. But the history simply didn't differ enough by race in the older group to cleanly mathematically explain the paradox.
So, biology couldn't fully answer the question. The shield theory failed.
Right, so if the answer isn't in the biology, it has to be in the behavior.
What did the behavioral data reveal then?
The behavioral data was the key to unlocking the paradox. The data revealed some stark, fascinating behavioral differences within the older demographics that leveled the playing field.
Okay.
When the researchers looked closely at the questionnaires, they found that white older men reported significantly higher rates of having anonymous partners in the past month and significantly higher rates of having sex in exchange for money or drugs in the past month compared to the Black older men.
Oh, I see where you're going with this. The behavioral risk profile completely flips.
Yes, it does.
The white older men in this specific urban clinic setting were making individual choices to engage in highly risky sexual behaviors. And those individual choices artificially raised their infection rates high enough to match the infection rates of the black older men, effectively neutralizing race as a statistical predictor.
That is the leading theory. The high-risk behavior of one group rose up to meet the systemic risk of the other. And it ties into a broader epidemiological concept regarding sexual networks in older age groups.
How so?
Well, in your 20s, sexual networks are often highly segregated by race, geography, and college affiliation. But in older age, especially in a dense urban environment like Baltimore, the specific pathways that lead an older adult to seek out an inner-city STD clinic might select for a very specific type of high-risk network.
Interesting.
It is a network that brings different demographics together into a shared pool of risk, leveling the playing field regardless of race.
Yeah. Think about what this means on a sociological level. If you are listening to this and you think about how we structure healthcare, this is massive. If race is typically a proxy for systemic lack of healthcare access in your 20s and 30s, does aging somehow act as a great equalizer in sexual health risk?
It seems that way.
It really suggests that as we age, the specific individual behavioral choices we make, like seeking out anonymous partners or stubbornly ignoring condom use, begin to matter vastly more than the systemic demographic categories we were born into.
It is a profound shift in how disease moves through a population.
Yeah.
And it completely changes the job of a clinician.
Yeah, the doctors have to adjust.
If you are a doctor sitting in an exam room, you cannot rely on the typical demographic assumptions or the statistical algorithms that you use for a 20-year-old.
Yeah.
The predictive models completely fail you with an older patient. You can't look at their demographic profile and guess their risks.
So what do you rely on?
You have to rely on why the patient actually got in their car and drove to the clinic in the first place. Their symptoms.
But relying on symptoms is a disaster waiting to happen, isn't it? Because as it turns out, older patients handle symptoms very, very differently than younger patients do.
Having physical symptoms is obviously a universal predictor of an STI across all age groups. If you have burning urination or a visible lesion, the odds are extremely high that you have an infection.
Of course.
But it is how older adults react to the onset of those symptoms that is deeply problematic, and it contributes massively to the silent spread and the severe clinical outcomes of these diseases. The Hopkins researchers understood they needed more context here, so they performed an extensive literature review to supplement their clinic data.
Right, looking at other studies.
Yeah, pulling in studies from around the world on how older adults behave when they get sick. And the data on delayed care is shocking.
There was a specific study mentioned in their literature review, the Got It All data. I believe it looked at patients in the UK.
Yes. The GOT study looked at older patients attending genitourinary medicine clinics in the United Kingdom. And what they found was that nearly 44%, specifically 43.8% of symptomatic older patients waited over 2 weeks to go to the clinic after recognizing their symptoms.
Wait, almost half of them.
Almost half of them just sat around in their homes with active, burning, painful, or visible symptoms for more than 14 days before picking up the phone.
I picture this exactly like the check engine light on a car.
Oh, that's a perfect way to look at it.
Imagine a 22-year-old driver. The check engine light comes on, and maybe they panic a bit, they pull over, they drive straight to the mechanic, or at least they plug in a diagnostic tool. They want to fix it immediately because they don't want their car to explode.
Right.
Now imagine a 65-year-old driver. The check engine light comes on, and instead of going to the mechanic, they take a piece of black electrical tape and stick it right over the light on the dashboard.
Just ignore it.
Exactly. Why? Because they know exactly what kind of off-road driving they've been doing to make that light come on, and they are too mortified to admit it to the mechanic.
The embarrassment factor cannot be overstated here. When the researchers in the UK asked those patients why they delayed care for over 2 weeks, the answers were heartbreakingly consistent. They cited a wait-and-see approach, desperately hoping the problem would just magically resolve itself.
Which it never does.
No, it doesn't. But the foundational reason driving that delay was profound, paralyzing embarrassment. The stigma associated with having sex in older age, let alone contracting a sexually transmitted disease, is so intense that they would rather suffer in physical silence and risk severe permanent health complications than face the perceived judgment